with the strategies of NAT. Professor Liu Yunjiang, I have a question for you. DB05 tells us dual chemo, dual targeting, and we can add ADC. In DB11, if ADC after ADC THP will do well, then ADC is 4 cycles only, and patient could tolerate that better. Based on the DB11 data, Professor Liu, will you put ADC to NAT setting, or use regular therapy, put ADC in adjuvant therapy? Whichever way will change our practice, Professor Liu. Thank you, Professor Junjie. This is a very sharp question. For TDXD, in later lines, let's push to early lines in the intensified therapy of adjuvant therapy and in NAT. They got clear results. Professor Geyer showed DB05 and also DB11. Professor Junjie put 1811 into an AT setting. You shared the results last year, and this is not inferior to TCH or HB. Then in AT setting, should we go for ADC or TCB, AC, THP, or THP, or whatever? ADCs, for sure, have the right scenario for application, but should we use ADC for all NATs? THP has the least side effects. It's easier to manage the patients. TCP, HP has bigger side effects. For AC plus THP may not be appropriate for HER2 in an AT setting, and this is less used as a regimen. And we'll choose those who tolerate well, younger patients, and some could be treated with this regimen. So we may choose TDXD, whether it's 1811 or 2122, which are domestic counterparts. So maybe after surgery, we have HP as adjuvant therapy. This could be different strategies. We need to collect more evidence through studies. There will be more explorations in the trials. That's my comment. And Professor Zeng Xiaohua, if you go for THP, THP is not working, go to TDXD. If there is PCR, go for HP, then go on with advanced therapies. Then that is in line with DB05. How do you look at it, especially in that flowchart? Thank you, Junjie, for your question. I've learned a lot today after the presentations by professors, and I could see TDXD is developing very well, and I see new evidence for intensified adjuvant therapy. You and Professor Liu mentioned, I don't agree to have sequential therapy in NAT setting. And, after 4 cycles of NAT, AC was effective, for example, and if you change suddenly, I don't do it. And if this patient is not responding, I change to chemotherapy. If this cannot be operated, as you said earlier, 4 cycles of, or 6 or 8 cycles of THP. If THP is working, I will go on with it. I will not switch. If this is working very well, and if the patient is not sensitive to the new therapy, it's not that you will do better if you switch to a new therapy. So if this works, go for it until there is SD. And at SD in NAT, after 2 cycles, there is SD, change to another strategy. It's not 4 cycles of THP, then go for 4 cycles of ADC, or the other way around. After 6 or 8 cycles of 8201, In NAT setting, sequential therapy for me is something I doubt. It's okay for adjuvant therapy. In advanced disease, if you go for sequential therapy and you have rescue therapy in advanced stage, you use a certain therapy to the utmost. And in the advanced stage, keep it gentle. And at early stage, we will achieve SD switch. I agree with the intensified adjuvant therapy. We've used TDM1 for patients. As Professor Yuan said, TDM1 reduce the platelets very much. A patient of mine recovered in 2 months. I could not go on with the 14 cycles of TDM1. And for the advanced use of 8201, degree 1 and 2 ILD happened, but now for 3 and 4, in intensified adjuvant therapy, I don't use TDM1, I use HP. I worry about side effects of TDM1. For adjuvant therapy, there's no disease burden, and if patient die because of ADC, you have a lot of pressure on your mind. And Professor Geyer mentioned, deaths, are those deaths related? And for the HER2 3+, 2+, are there any subgroup analysis? And are there any differences in PCR?
Yes, the first question is based on DB05 and the DB11. So which treatment you think is the best in the neoadjuvant and the adjuvant now? And the second question is if the patient received TDXD followed by THP in the neoadjuvant setting and have non-PCR, so what treatment you will give to those kind of the patients in the adjuvant?
My honest answer right now is I don't know. I mean, I think an issue that always troubles me a little bit is when you design trials, you have to pick a set number of cycles. What are you comparing to? You're always comparing to standards. And so we were looking, can we replace 4 cycles of AC with 4 cycles of TDXD? A very narrow question, very appropriate. And based on PCR, the answer would appear to be yes. Now, unfortunately, that study did not control for adjuvant therapy. Patients on the control arm didn't receive adjuvant TDXD. There's lots of questions that we're going to have to be very thoughtful about doing trials if we're ever going to move past our opinions. And we all have, our opinions are all valid. They're all driven by data, experience, and things. But ultimately, it would really be nice to understand this whole concept to me of, do you have to lock into a fixed number of cycles? I'm hearing some folks say, no, if it's working, keep going. And with THP, my impression of the data is that if you limit your THP to 12 weeks, you have a lower PCR than if you take it out to 18 weeks. And I think NeoCarp was a good example. It looked at carboplatin, but you see with THP, the PCR rates are higher than they were in the Compass HER2 trial. It's cross-trial comparisons, but there's so much there that we don't know. So and if you have a non-PCR, if I treated with 4 cycles of TDXD and I still had an RCB3, it didn't look like it did very much, I wouldn't keep doing that. It wasn't helping. If I have an RCB1, then I'm thinking, well, okay, if I had gone and given 6, would it have gone away? Now am I committed to giving, and I sure wouldn't give 14 adjuvantly. The most I would give would be 10. I would, from my view of it right now, our maximum TDXD exposure in early setting is 14 cycles. And if I move some of that up into the adjuvant setting, neoadjuvant setting, I'm not going to make them get more. I don't understand that sort of thinking. So for me, and if I have a high risk patient that hasn't responded well to THP, I'm probably going to give TDXD, but then see how I do with that to try and make my adjuvant decisions? Because then you get in, well, is TDM1 inactive in that patient, or could it be worth, we need trials to tell us all that. I think there's just so many questions that this brings up. But I think with DB05, it was designed for IDFS for the definitive main endpoints, and it performed very well. We have lots of questions, there are 14 cycles necessary, but we can see that DB11 is interesting. It showed an increased PCR rate. The EFS is trending, but again, you've got patients exposed to TDXD versus patients not exposed to TDXD. So what does that mean? I'm not clear on that personally.